Thank you for taking the time to listen to this presentation. Just as a bit of background, I'm a pediatric critical care nurse at McMaster Children's Hospital and a PhD student at McMaster, working under the supervision of Dr. Lisa Schwartz. So she was obviously had a very important role in this project as well. So I'll be sharing some findings from this research that we conducted. I just want to mention that our project was funded by two COVID research funds, one based out of McMaster and one from McGill University. We also received research ethics approval from the Hamilton Integrated Research Ethics Board, as well as the McGill Faculty of Medicine Research Ethics Board. So I'm sure I'm preaching to the choir, but obviously we all know that research plays a really critical role during emerging pathogen pandemics. And at the phase of the pandemic, when we were doing our research, we were observing that there was a big focus, especially on interventions for patients who were suffering from COVID, especially in the ICU. Several members of our research team had been involved in conducting research about ethical dimensions of the Ebola epidemic in West Africa. And so we were aware that there's a real risk or potential for there to be tensions between the priorities of public health, clinical care, and research, that those don't always align well. And so we wanted to explore what were some of the experiences of people involved in COVID studies in the first wave. For the purpose of this presentation, we were also interested in how the complexity of adaptive platform trials might also influence that experience. So our study aim was to understand the moral experiences of health and research personnel with the production and utilization of COVID-19 evidence during the first wave of the pandemic, including their experiences with adaptive and adaptive platform trials. Excuse me. So our study was a qualitative study using interpretive description methodology. And the overall study, we conducted individual semi-structured interviews over Zoom, because it was in the first wave, between May and September of 2020. So first wave of the pandemic. We conducted 26 interviews. Of those people, we interviewed 10 people specifically mentioned that they were either in leadership positions or involved with adaptive or adaptive platform trial. An adaptive trial, and there was 9 that were specifically an adaptive platform trial. There were other participants who mentioned studies, especially bedside nurses and other staff who maybe didn't know the name of the trial they were involved with, but these were people we could specifically identify. The demographics for those 10 participants are on to the left, or the right, I'm sorry. You can see there's a predominance of clinician investigators. So these are folks who were maybe primarily a clinician, physician taking care of COVID patients and might have been a LPI for a COVID study. And the majority of our participants were from Canada, but we did have participants from Eastern Europe and the US, as well as other countries in the larger group of participants. So I'll just be talking about a couple of our major themes that emerged from the study. The first one, a theme that was really important in the overall study, was this idea that for people early in the pandemic, research was really seen as something that we could do for our patients when there really didn't seem like there was anything else we could offer. We didn't know much about this virus. And so particularly for that group of 6 participants who saw themselves really as doctors first and researchers second, for them, they felt this compulsion to do something, as was talked about in the session this morning. But at the same time, because of their conviction around evidence-based practice and not wanting to do harm, they felt like they were kind of stuck. And the only option they really had was to either start up a study at their institution or try to find another study that they could become involved in. And there's a quote from a Canadian clinician investigator that really illustrates this. They said, "Because of the paucity of data, we said that really no therapeutic intervention should be undertaken outside of a clinical trial. And so I think it's my ethical obligation to then provide a trial, because I can't tell clinicians and patients that they can't have these therapeutics without also providing a trial for them." And so this was a motivation for quite a lot of our participants. Importantly, there was a participant we interviewed from Bangladesh who was not part of an adaptive platform trial, who talked about struggling to try to find external partners to support them so that they could increase the quality of the data they were collecting and the research they were doing, and how they felt quite ambivalent about a common practice at their institution of giving untested therapies for COVID. This is a source of moral distress for them. This next theme I want to talk about is the value that a lot of our participants saw in how adaptive platform trials are easily translatable to practice in their view. A lot of participants talked about how during a pandemic, it was really, they felt that any research that was happening for it to be ethically conducted needed to be quite relevant to practice immediately or soon. That research that had a long time before it could be translated to practice shouldn't be done during a pandemic. And so that was a really positive point in many people's minds for adaptive platform trials. This one clinician investigator said, when we did the adaptive platform trial, I have to say that it put me at peace with a little bit with randomized controlled trials because it does feel closer to real clinical life. They went on to say, the adaptive trial I find is an amazing thing because it's pragmatic, because it reflects what we always do in clinical care. So it kind of mirrors what was said earlier. Another important theme that came out of our study, though, was that a lot of participants had concerns about the ability of patients and families to give authentic, informed consent in the context of COVID, where there was not a lot of other options. There was fear surrounding the infection, high mortality rates, and also separation from their family and loved ones. There was also concerns in some settings where multiple studies were recruiting in the same pool of patients, which was often very overwhelming for patients and their families who were overwhelmed. There's a quote from our research coordinator who was responsible for an adaptive platform trial who said, and so it's hard to navigate the consent process and to not cause burden to families, especially since they've never seen their family member, right? They drop them off at the ER and that's it. This is an important concern that came up a lot for different participants. Adaptive platform trials were seen to be particularly challenging in this way because of the complexity of the methodology. And one a regional lead for a large trial explained, one of the big ethical challenges is, as we have multiple different interventions, REBs want us to enumerate all of the side effects associated with all of the interventions. So our consent form is over 20 pages right now, which really is not a consent form. There's no way someone can read it realistically. That is an important piece. And then the last theme I'll talk about today is around risks and workload realities for bedside staff. All of the participants we spoke with agreed that there was an ethical obligation of researchers during COVID to not cause excess burden on bedside staff who were trying to balance their clinical priorities. The reality was, though, that because of the absence of research staff in most clinical departments, a lot of those tasks did fall to bedside staff. And sometimes there was, the reality was that also research was piggybacking on, or you know, not taking advantage, but relying on the risks that bedside staff were already taking during their clinical treatment. So there was also, we noticed a discrepancy between how researchers who were in leadership positions saw the amount of burden that fell on the bedside staff. A really important example of this was when remote consent was being done by a research coordinator, the tasks that fell to the bedside nurses to sort of help coordinate that. And there was an example specific to an adaptive platform trial where a research pharmacist, she was a research and clinical pharmacist, who described how she was taken on the role of trying to embed the intervention administration process into the electronic medical records so that the nurses could give the medication. And they said they're calling these studies adaptive design. So they're all of a sudden changing arms to apply these to new agents and interventions. So basically, I'm rebuilding these studies again under the same name, and there's not always an appreciation of the workload that requires. And then the second quote on the slide is just looking at, especially for clinician investigators who were working in low resource settings. This is someone from Eastern Europe. They described how they wanted to offer this study, but they were trying to balance that with their clinical duties, which is quite challenging. And just to wrap up, because I know I'm running out of time, the study that basically in summary, the idea is that because of these participants' commitment to evidence-based practice, research really started to be seen as the only thing we can offer patients during this phase of the pandemic. And I think sometimes we critique the proliferation of all these really poor quality studies that were done at that phase, but I think that came from, in part, a motivation to do something. People felt compelled to do something. And I think adaptive platform trials do have an important role in potentially increasing access through these large global partnerships. But our study does raise a couple of important questions for consideration. As all qualitative research does, I can't give you a definitive answer, but it raises some questions for you to reflect on. One is, how do we make sure that clinicians working in low resource settings are connected with these large trials so that they feel also that they can do something for their patients? It also begs the question though around therapeutic misconception. Is the purpose of a clinical trial during a pandemic to offer something, or is it to answer the research question and be able to then expand access to the treatment? So there was some interesting questions there. And finally, how do we support clinicians who inevitably won't be able to be connected with this type of rigorous, complicated study to feel that they still can offer something and not just be waiting for results from the studies? Thank you so much. I really appreciate our funders for the support, and also especially to the people who spoke with us at this really stressful phase of the pandemic for taking the time. We're in the middle of drafting a manuscript based on these findings, so I'm very, very open to any feedback, comments. Please reach out to myself or Dr. Schwartz. Thank you.